Hi friends, welcome to Plexus Ortho. My name is Dr. Kannan Kumar and today we're going to discuss one of the MCQs that we put up a couple of days ago in the Telegram channel. So the MCQ was MCQ number 252. Which activity is difficult to perform for a patient with anterior cruciate ligament injury? It's a very important question about biomechanics of the anterior cruciate ligament and the knee ligaments. So you must know everything in the anatomy section about these ligaments and also what they do and how we reconstruct them and what are the problems with this. So the answer to this question was walking downhill, right? So the ACL prevents the anterior translation of the tibia over the femur. The anterior translation, A for anterior, A for ACL and A for anterior. Anterior translation of the femur over the tibia is stopped by the anterior cruciate ligament, and this helps us in walking downhill. So you will have a difficulty in walking downhill if the ACL is torn. Walking uphill is basically PCL's function. Sitting cross-legged and getting up from a sitting position are no way related to anterior cruciate ligament. So let us go in a little bit of detail about anterior cruciate ligament injuries, because these questions are often asked in your NEET PG exams, and so you must be well prepared to address these questions. A little bit about the anatomy. ACL originates from the lateral femoral condyle. Remember that. It originates in the lateral femoral condyle somewhere between the 9 to 11 o'clock position in the right knee, and it inserts into the tibia more on the medial side. So this is the anterior cruciate ligament. Anterior cruciate ligament has two parts. All of us know what are the two parts. It has two bundles. It has the AM bundle and the PL bundle. And this is how I remember it. The mnemonic is ample, AM, PLE. So AM for anteromedial bundle, right? Anteromedial bundle, and PL for posterolateral bundle. Posterolateral bundle. And E you add because the posterolateral bundle is tightest in extension, PLE, and the anterior medial bundle is tightest in flexion. So the mnemonic to remember is ample. There are two bundles, anteromedial and posterolateral bundles, and E is for the posterolateral bundle is tightest in extension, whereas anteromedial bundle is tightest in flexion. Okay, so what is the basic function of the ACL? It prevents anterior translation of the tibia over the femur. And what are other anatomical quirks of these? This is an intrasynovial structure, and therefore healing is very poor. The blood supply is from the medial genicular artery. The blood supply is from the medial genicular artery, right? But the healing potential is very poor, and that is why anterior cruciate ligaments have to be reconstructed, and they cannot be repaired in any form or method. So this is in brief about a little bit about the anatomy, the bundles, and what they perform, right? Now, how do they get injured? They get injured more in cases of more in females rather than males, and the reason is because the notch is smaller, the femoral notch is smaller, the ACL gets impinged, and there is some hormonal imbalance in the anterior cruciate ligament which makes it a little more weaker. So as and when more and more women get into sports, we are going to see more and more anterior cruciate ligament injuries. So there is a high incidence of anterior cruciate ligament injuries in females as compared to males. This could be also an MCQ question in the future exams. The mechanism of injury is usually a pivoting injury. When the patient or the athlete tries to turn or cut, for example in badminton, or taking a run, changing directions in case of cricket, there is a disruption of the anterior cruciate ligament. This can also happen with a lateral or a valgus force that is applied to the knee in contact sports. Meniscal injuries are very commonly associated with ACL injuries. The most common meniscal injury associated is a lateral meniscus injury. The lateral meniscus injury may be associated in up to 54% of ACL injuries. So one must always look for these injuries, repair these injuries, and do something to the meniscus if it is injured in anterior cruciate ligament injuries. How do you examine these patients? Examination of these patients is done by the following test. The most specific and sensitive test that can be done is called the Lachman's test. The Lachman's test is where the patient is lying supine and the knee is flexed about 20 to 30 degrees, and the examiner holds the thigh in one hand and the tibia in the other, or the leg in the other hand, and tries to translate the tibia anteriorly over the femur. If the examiner is able to do this significantly as compared to the opposite side, this indicates a positive Lachman's test. So the Lachman's test is the most sensitive and most specific test for ACL injuries. So therefore, whenever there is a question which is asking for the most specific or the best test for anterior cruciate ligament testing, the best test is the Lachman's test. The Lachman's test. So remember, the Lachman's test is a very important test for these kind of injuries. The second test that can be done is called the anterior drawer test, which is the more commonly seen in the textbooks and pictures and etc., where the knee is bent to about 90 degrees. The knee is bent to 90 degrees, and the same thing is done. The tibia, we try to translate the tibia over the femur, and this is less sensitive than the Lachman's test, but does work, and it is the second most commonly done test for anterior cruciate ligament injuries. So that is the anterior drawer test. The other two tests that can be done are the pivot shift test and dial test, which we will not go into details. Hopefully they don't ask you this in your exam, because it's a PG level question. Hopefully it doesn't come in the NEET PG exam. Of course, the final test you should do the McMurray's test. McMurray's test is to identify for meniscal injuries. As I have said, lateral meniscal injuries can occur in about 54% of the cases. So you must always look for meniscal injuries, and McMurray's test must be performed in each and every case. How do you investigate these cases? You can initially the patient will present with a lot of swelling. They will hear a pop in the knee, and they will present with hemarthrosis because the medial genicular branch is ruptured and there's a lot of bleeding in the knee. So patient will present with a lot of guarding and tenderness and swelling. You must get an X-ray to rule out any kind of fractures. But the patient will not let you do these Lachman's anterior drawer tests, etc. These cannot be done at this stage. You can do this after a few days or a few weeks after the injury. Right, so what the first thing you do is an X-ray, radiograph, make sure that there are no fractures. Then you move on and get an MRI scan done. It's not an emergency. An MRI scan can be done down the line. Okay, so they may show this MRI image, and it has been shown a couple of times in the NEET PG exam, and they may show this MRI image and ask you what structure is injured. If you can see, this is the sagittal cut of the knee joint, and here you can see clearly you can see the ACL ligament, which is starting from the tibia and inserting into the lateral femoral condyle. You can also see the PCL in this picture, right? You can see it very clearly. It is not cut, or it is not wavy, or it is not absent. Whereas in this picture you can clearly see that there is no ACL, or there is some kind of wavy pattern that you can see. It's not dark, and it is not distinct, and there is something wrong here. So in these cases you suspect an ACL injury. Here you can see the PCL looks intact and taut, but the ACL looks wavy, and it looks like it is collapsed into the joint, and this probably indicates an ACL injury. So this is how you recognize an ACL injury. Right, what are other radiographic features? Sometimes you can see there is one pathognomonic feature which is called as there's a small fracture which can happen in the lateral tibial condyle. This is called as a Seagon's fracture. This is a pathognomic feature seen in about 75 to 100% of ACL injuries. Right, this is what is called as an injury to the ALL ligament, anterior longitudinal ligament is injured with a piece of bone. So this is supposed to be pathognomonic for ACL injuries, and it could be asked in an MCQ question, what is a Seagon's fracture? What is the most pathognomonic feature of ACL injury? And that is an ALL injury. Also you can see what is called as bone bruising, because the tibia translates anterior to the femur. This portion of the tibia, the posterior portion of the tibia and the anterior portion of the femur bang against each other. So the anteromedial portion or the anterior portion of the femur and the posterior portion of the tibia bang against. This is the posterior portion and this is the anterior portion. They bang against each other and they have a bone bruise or bone marrow edema. This is also an indirect indication of ACL injury, and this can also be seen in MRI. So these are some of the radiological features of ACL. So what are the radiological features? What is the most sensitive and specific investigation? It is a MRI investigation. MRI shows ACL injury. X-rays can show ALL injury or Seagon's fracture, which is pathognomonic. We can also see bone bruise in the anterior portion of the femur and the posterior portion of the tibia. How do you manage these ACL injuries? ACL injuries in older age, 50, 55 and 60 and above, can be managed conservatively. Okay, so these patients who are not very active athletically can manage their life without ACL reconstruction. And do you repair these ACLs? As I've already said, no repair, because there is no role for repair. There is an intrasynovial structure, and it has very poor healing capacity, and all attempts at repairing it, all the literature, everything shows that repair doesn't work and it is of no benefit, and patient will not have a successful outcome after repair. So repair is not an option anymore, right? So please do not take on repair when you get these questions. So what is done usually? We reconstruct the ACL ligament. Reconstruction is done after a few weeks from injury to wait for the hemarthrosis and the inflammation to come down. Then you do the reconstruction. The reconstruction is basically done with the help of multiple grafts. So the grafts commonly used are called patellar bone tendon graft. So you take a, so if this is a knee, this is a femur, this is a tibia, then you have the patella here, and this is a tibial tuberosity, and this is a patellar tendon. So you take a piece of bone of the patella along with the tendon of the patella, and then take a piece of bone of the tibial tuberosity, and this is used to reconstruct the anterior cruciate ligament. The other graft that can be used is called the patient's own autograft, called as hamstrings. Hamstrings can be used, gracilis, and the semitendinosus tendon can be used. These two tendons are wrapped 4 times, and it is called quadrupled hamstring graft, and this can also be used to reconstruct the ACL. The other allografts that can be used include Achilles tendon graft. We can use hamstrings allograft. Allograft is from some other cadaveric source, and we can also use the Achilles tendon, peroneal tendons graft, and all these kinds of grafts can be used to reconstruct the anterior cruciate ligament. Okay, so these are the various methods in which we can reconstruct the anterior cruciate ligament. One thing you must also remember is the anterior cruciate ligament reconstruction is generally done now in arthroscopic. Arthroscopic provides the best results. Arthroscopic is done by the anterior lateral and anterior medial portals. You must understand that the anterior medial lateral portal is through where the camera is placed, and the anterior medial portal is through where the instruments are placed. So that in brief was about anterior cruciate ligament injuries. This question could be asked. It's very often asked because. Thank you very much for hearing me out. My name is Dr. Kanan Kumar, and this is Plexus Ortho. Thank you.